Okay. So this is the disclosure. And just I want to say that this talk is relevant to all couple diversities and sexual fluidity. What I'd like to show you is the simple idea of how you manage sexual and intimate issues in Parkinson, and this is based on over 25 years of experience and counseling over 500 people with Parkinson on research data, but especially on interdisciplinary teamwork in two movement disorder institutes. One is at the Tel Aviv Medical Center, and the other in the Sheba Medical Center, both in Israel. And just lately, we have published a study where 70% of our patients said that they do want information or advice on sexual health issues. So first, when should we ask about it? We can do it when addressing non-motor symptoms. We can do it when we ask about urinary, bowel, or gynecological problems. Now, why should we talk about that? There are so many problems in Parkinson. So first, because it is really common. Over 50% of the patients complain of some sexual problems, which is part of the non-motor symptoms. Then we know that sexual problems affect, problems of patients affect their partners. Then, surprisingly, older people have sex, yeah. At the age of 62 or 69, over 50% of the men and 40% of the women still have intercourse. And even over the age of 70. You have a fine activity. And then the last reason is that sexual satisfaction protects from cognitive decline and predicts general life satisfaction. So what in Parkinson can contribute it? The motor symptoms, of course, because if you cannot hug, you cannot touch, it's difficult. Then the non-motor symptoms, we have the neuropsychiatric one, cognitive impairment, attention being in depression, apathy, fatigue, but also autonomic dysfunction. Sleep disorders, for example, if you don't sleep in the same bed, or you sleep in separate rooms, and you know, in a funny way, most of the people have a fixed time for having sex when they go to bed. And here you don't have the bed, the mutual bed. And then pain can affect the problems. And then we have various psychosocial issues which have to do with couple relationship, with the burden, with social isolation, but also medication. The dopaminergic ones, but also medication for non-motor symptoms like antidepressant, or medication for other comorbidities. Now, what are the problems? So men and women have decreased desire, arousal, and orgasm. And the intervention is quite easy. First we have to treat depression and anxiety. We have to administer medication for pain before having sex. We have to test testosterone deficiency. And if there is a problem with orgasm, for example, because of antidepressant, we can think of lowering the dose or switching the medication or suggesting a weekend vacation, which is a vacation of 24 hours to 48 hours without the medication. But we also can give some practical counseling, like planning sex when fatigue is minimal, choosing comfortable position and not having to move too much because of the motor dysfunction, shifting from goal-oriented intercourse into pleasure-oriented intercourse or any other intimate activity. And sex therapists can really counsel specifically for each couple. Then we have specific problems of women, mainly vaginal dryness or painful intercourse. And the intervention is first stop the pain, meaning shift from intercourse, stop intercourse, go to intercourse, then find some gynecological treatment like the local or systemic estrogen, use vaginal lubricants, refer to pelvic floor physiotherapy, and to sex therapy. Then we have sexual problems of men. Erectile dysfunction is the most common one. And we have first, of course, to treat depression, anxiety, testosterone deficiency. We can refer to urologist or endocrinologist. We can consider other diseases which affect erection. But if you prescribe PDE5 inhibitors, remember that there is a slow gastrointestinal motility, meaning that if a patient takes an erection pill, you have to wait longer than 1 hour. My patients wait 2 to 3 hours before their medication is effective. And referring to sex therapist also helps. Then we have a surprising sexual problem, sudden premature ejaculation, which did not exist before, and it appears shortly after administration of PD medications. And the intervention is first explaining to reduce stress, and then referring to a urologist or to a sex therapist or to both. So up to now, I spoke about decreased sexuality, but we also have increased sexuality. I would like to refer to 2 types. One of them is the sexual desire discrepancy, meaning a gap because the patient with the Parkinson restored his desire or her desire, and the partner did not. So first we explain, because we reduce the tension, then we have to reduce partner burden. We can refer to sex or couple therapists, and only in rare cases we will use medication adjustment. And then we have the real hypersexuality, which we call it compulsive sexual behavior. In these cases, we have to adjust dopamine agonist or L-dopa doses. We have to consider advanced PD therapies like the DBS, like the LCIG, or mainly involve the multidisciplinary team. Why? Because we have to support, to guide, and to prevent sexual health risks, like sexual transmitted diseases, AIDS, being abused or abusing others. Just a minute. Now, what about future technologies? We are talking about the future, you know, all the digital devices. What do we have now? So we have one of them is the humanoid therapeutic sex robots. They can be as aids to people with dysfunction or disability or loneliness, teaching them sometimes or being a partner. Then we have special remote control suits, which are very good for arousal and orgasm in people with disabilities. We have the virtual reality technology, which can treat sexual problems due to anxiety, phobias, pain, trauma, eating disorder, or motor rehabilitation like post-stroke. And also we have something new, which is my avatar will have sex with your avatar. Not my body with your body, but our avatar. Is it realistic? Yes. The first metaverse space, sexual wellness space, was opened in July 2022. It is easily accessible with the virtual reality devices. It's suitable for big audience. Everybody can come, all people from all diversity, from all ethnicity, with all disability or non-disability. They can explore sexual wellness, talk about it, learn about it, have some, and this is an example of the picture of one avatar. You can choose your avatar and the other avatar. So I don't know what I will talk in the next Congress in 3 years in the WPC, but this is the state now. And my key takeaway is ask about sexual health and sexual satisfaction. And if you are people who live with Parkinson, ask your health professionals. Tell your patients that sexual problems are common in Parkinson. And today there are effective treatments. But first we have to treat the depression, the anxiety, testosterone deficiency, and pain. And then we have to refer to experts. I mean, you as health professionals do not have to be expert in sexual health, but you can refer to them and help. Thank you very much, and if you want to discuss with me, I am at Abstract. I think it is P2002. This is my refer number. This is not the right number. So P02002, and I'll see you there. Thank you very much.
Thank you, Gila. Very important issue that also affects globally.